Hello, everyone. Today I have the pleasure of speaking with Dr. Anique Ducharme. Dr. Ducharme, why don't you tell us a little bit about who you are and what you do?
Well, I'm a heart failure transplant cardiologist at Montreal Heart Institute. I'm the founder and the director of the heart failure clinic here. So a lot of work these days.
I can understand it must be a very hectic time with everything that's going on. So, Dr. Ducharme, I understand that you have a new medication continuum initiative that's being developed. Can you tell us a little bit about that?
Absolutely. What we do, we have an order set when the patients are admitted so that we don't have to write down every single line. And what we've decided is since an hospital admission is somehow that the treatment we have is not extremely successful. Now we've implemented that in the list of medication, if the patient is already on an ACE inhibitors and a patient has heart failure with reduced ejection fraction, what we do it is almost mandatory that you switch. So you stop the ACE, and at the beginning, we were a bit worried that if you stop the ACE inhibitors, you have 36 hours of washout before starting the sacubitril valsartan. So what we've done is, as soon as the patient is in, the patient is automatically switched to valsartan without the sacubitril components. So that at least if the patient is discharged or leaves or there's something happening and they're going with a list of medication that includes a renin-angiotensin system inhibitor, because we've had at the beginning, like that was 2.5 years ago, a few patients that was discharged on weekend, and we were afraid that they would leave with no RAS inhibitors, especially if they're discharged within the 36 hours.
Understood. So can you tell us a little bit about the need for such an initiative? I mean, why did you have to develop the system? We understand that there's a lot of evidence around sacubitril valsartan, and so what was the impetus to develop this this platform of yours?
Well, the goal was mostly to uniformize the practice because we're a heart-only hospital, but we all have our own specialties. Some are EPs, interventional cardiologists, or heart failure transplant. So we want to make sure that every patient get the best treatment regardless of who's going to be the attending. And so that was the main rationale behind that.
Okay. And so since initiating this medication sort of a continuum or medication platform of yours, have you noticed an increase in the use of evidence-based therapies for the treatment of patients with heart failure and reduced ejection fraction?
Well, now once they're seen at the heart failure clinic for the first time, not the majority, but I would say almost almost half are already on sacubitril valsartan. Obviously, you have new patients that were not didn't have their month of RAS inhibitor, which is the rules in Quebec before switching. But I would say there's much more evidence-based treatment, and not interestingly, not only for this agent, but also for MRA. So we're pretty happy with that.
And do you find that in general across Canada, there is low use of these therapies, hence the need for such programs to optimize the use of evidence-based therapies that have mortality and morbidity reduction evidence in patients with heart failure and reduced ejection fraction?
I don't have the data for whole Canada, but I have the data for the 43 clinics in Quebec Heart Failure Society. And we know that just about half of the patient have MRA, and below 50% have sacubitril valsartan. So there's a huge gap that we need to fill. So we're trying, obviously this is not much only in our hospital, but we're trying to do it try to improve the care of those patients.
And can you tell us a little bit from your experience as to some of the reasons for maybe the inertia to initiate some of these evidence-based therapies? From your experience and that of your colleagues, what are some of the barriers to implementing these medications?
Well, I'm not sure there's inertia, that's for sure, but there's also, when the patient comes in hospital, they stayed less than 5 days, and you have to start all those medication. So I think it needs time to implement those treatments. So there's certainly some part of inertia, but there's also some physiological limitation. If the patient has like a blood pressure of 80, we cannot start everything at the same time. So
Mm-hmm.
that's why I think the goal is really to work as a team with, we're working a lot with pharmacists and nurse practitioner, nurse clinician, so that everybody in the same going in the same direction, because it's very easy if the patient say, okay, I have fatigue. Oh, it's your beta blocker. I just stopped it. So I think it's really a team effort to try to improve that. Uh, but we need to do better. I absolutely agree with you.
Can you tell us a little bit about if other hospitals want to implement such a system? Is there a place where they can go to find out more information about what you've done and some of the experiences you've had with this type of system? Because I could imagine that a lot of programs, whether it's heart failure or cardiology, would like to find ways to increase the use of evidence-based therapies. Where can they find out more about what you're doing?
I will be happy to share. In fact, we're probably going to share within a month on the Canadian Heart Failure Society website, and which has also a French site, which is insuffisancecardiaque.ca. So I think it's easier. It's easy. Anybody in the team can share it without any problem. The goal is really to improve care to those patients.
And when it comes to actually increasing the therapies, do you find that there's ever barriers from the institutional side? So, for example, maybe some of the drugs are not available on formulary, or it's harder to initiate these medications as an inpatient. Or do you find that some of the barriers come from physicians being a little bit more uncomfortable to start these medications and therapies? Just from your own experience, eh, have you seen any of these come into play?
Well, I think many of them come into play. The obviously you have the patients who always tell us that they take too many drugs and they want to get rid of one or two. So this is an obvious one. From the institution perspective here, the pharmacists are very much involved in the heart failure care. So I don't see a lot of barrier on that matters. But obviously, we have data for de novo patient and in hospital. But if the patient has not been on a RAS inhibitor for at least a month, it is not reimbursed. So this is a major barrier, I would say.
Mm-hmm.
And the other one that is very, I would say, specific to COVID-19, but not unique to the situation we're living, patients are afraid to go and get their labs done, and it's very difficult to implement a treatment without having the creatinine and the potassium. So that, I would say those are the main barrier. Another one is, especially in a patient class 2, patients are doing fine. So both the physician and sometimes the physician and the patients are a bit reluctant. Why would you change something that works? Even though we know that such a thing as a class 2 stable patient does not really exist because they're at high risk of having cardiovascular events.
Completely understood. And certainly it takes a lot of discussion between the healthcare providers and the individuals with heart failure and reduced ejection fraction for them to communicate why these medications are needed. And I completely agree that sometimes there's a little bit of pushback because people feel they're on too many medications. But of course, a lot of these do have the ability to improve morbidity and mortality and improve symptoms as well. And so speaking of COVID-19, can you tell us a little bit about how your clinical practice has changed since the pandemic with regards to your ability to manage patients with heart failure and reduce ejection fraction?
Well, for the outpatient, I would say regular cardiology clinic, the majority have switched to either Zoom or phone conversation, which is okay. I would say sometimes it's difficult. Okay, you have swelling. It's a lot of swelling, a bit of swelling, and it's not always easy. At the heart failure clinic, we've reduced by 50% the in-person visit, but we feel that it's still very important to see them. Uh, we have to convince them we're on the side of the research center, so far from the in-hospital. And we're an hospital that is called COVID-free or just about, so it's difficult to convince the patient to come in, but I think it's in many area it's mandatory. For all the optimization of medication, they're done over the phone, but the patient comes in the day before in the afternoon where there's nobody to do the blood test. There's no waiting line. They just have a number, and they're called the day after with their blood pressure and heart rate to be taken.
Okay, wonderful. Well, thank you so much for sharing some of your thoughts and your experiences, and we look forward to seeing some of the data on the Canadian Heart Failure website. So thank you very much for your time.
Thank you very much.